Good afternoon, ladies and gentlemen. My name is Karl-Heinz Kuck. I'm from Hamburg in Germany, and I'm your host today during this industry-sponsored symposium on robotics in electrophysiology. It's my great pleasure to welcome you to this important and very innovative session. If we go back into the development of robotic technology in treating patients with clinical arrhythmias, we have to mention the technology that was founded and introduced by Stereotaxis, the first company in robotics for treating patients with clinical arrhythmias. The company was founded in 1990. And shortly thereafter, our lab at the St. George Hospital in Hamburg was the second lab in the world, following David Lindsay's lab, to use this technology and to get early experience in developing technologies to treat patients with clinical arrhythmias. This was the time when catheter ablation of atrial fibrillation was introduced. And as far as these strategies have developed to treat patients with atrial fibrillation, also technologies have been developed to advance robotics in clinical medicine. And today we are going to review where do we stand today in the ablation of atrial fibrillation and more complex arrhythmias, and combining this with all the development that has been obtained and achieved over the last 30 years in robotics. And as you will see, there's a lot of advancement, and I'm really looking forward to this session, and I'm proud to chair that session today. I've shown you my industry relationships, and it's my pleasure to introduce the three speakers today: Dr. Peter Weiss, Dr. Tamas Szili-Torok, and Dr. Pekka Raatikainen. The first presentation will be given by Dr. Peter Weiss, and Peter is going to talk about innovations in robotics for electrophysiology, and he will give us a very interesting update. Please, Dr. Weiss.
Thank you, Professor Kuck and the organizers for this opportunity. Here are my disclosures. I would like to start with some brief thoughts about the current paradigm brought to the forefront by luminaries such as Professor Kuck himself, as well as many of the other leaders in our field, such that pull wire activated contact force sensing catheters have become the true standard for manual ablation procedures worldwide. However, if you look a little further into the data behind studies such as Takata, you'll find that even amongst these most experienced users in the world, there's actually a very wide variation in contact forces delivered during lesion formation, both within and between operators. And in fact, if you look at this study, such as this very interesting study from Atul Verma, where they randomized experienced operators to see the contact force numbers versus not see the contact force numbers using the same exact tools, you'll find that when you look at the quality of ablation lesions as determined by gaps in lesion sets, and you look at parameters that include contact force, such as contact force itself, FTI, ablation index, even power delivery, there's actually no real difference in the quality of ablation lesion sets when looking at these parameters. And more interestingly, when you look at one-year clinical outcomes between patients treated with operators blinded versus not blinded to contact force, there's no clinical difference. In addition, when we think about safety, I think we're all aware that these newer manual contact force catheters are quite stiff. And if you look at real world operators, such as this very large series from China with over 5,000 patients involved over 3 years in a very experienced operation setting, we'll find a twofold increase in cardiac tamponade since the introduction of these catheters. So maybe it's time to think about what is underlying here, that maybe there's a technology mismatch between our current tools and what we're trying to do. We have a stiff manual catheter being used in a flexible moving system, such that the catheter will always be bouncing around and moving around. And even though we're seeing contact force numbers such as 25 grams in this example, the reality is that the force is moving up and down with every breath, with every heartbeat, as the catheter moves around inside this moving system. So maybe it is time to think about a new paradigm, such as magnetic navigation. In this case, with Stereotaxis, we see a flexible catheter that's pulled by its tip through the tissue, through the chambers and against the tissues, allowing incredible precision in movement, extended reach into areas which could otherwise be difficult to reach within the heart, focal stable contact moving with the heart and allowing for great catheter stability, and also less traumatic interaction with a flexible catheter that simply cannot perforate the heart mechanically. Now, this was first introduced into clinical use for electrophysiology in the early 2000s with promise of a new era of safety, effectiveness, and efficiency. But I think many of us are also aware that at that time, things were overpromised and underdelivered. And led to perceptions that have been quite challenging, including questionable clinical outcomes, questions about inefficiency, how slow the system can be, the expense related to the system, especially the capital cost, and questions about the company itself, including lack of innovation and questions about corporate stability. However, the reality now is more than a decade of clinical experience with more than 130,000 procedures having been performed worldwide, more than 400 publications, of which more than 50 include head-to-head comparisons, and use in all areas of electrophysiology, including atrial fibrillation, as well as more frequent use in ventricular arrhythmias and in congenital, amongst others. Importantly, this is all with legacy technology. In fact, the ablation catheter that is currently being used was introduced in 2008. And all of the work that has been done has been with these legacy systems. Well, now there is the opportunity for a new generation, a new look at this. This is, in fact, our lab at Banner University Hospital in Phoenix with the new Genesis system. This is a lighter, smaller robotic system, articulated arm that allows for instantaneous catheter response. It also offers a full lab solution where we have the robotic system now bundled with the fluoroscopy, the table, the monitors, allowing a price range now. And this is important in thinking about moving this forward that is similar to a non-robotic lab, and also allowing integrated tech support. And also focused on a true open EP ecosystem, allowing current integration with multiple systems, such as the CARTO and Acutus mapping systems, which are fully integrated, but demonstrated use with other mapping systems as well, such as EnSite and Rhythmia, and integration with advanced imaging systems, such as InHeart, ADAS, Vivo. In fact, our early experience in this lab has included broad capabilities demonstrated with procedures, including use of EnSite integrated with CT and MRI mapping, Rhythmia, CARTO, including some procedures that have been outside of electrophysiology, including septal ablation here in a patient awaiting mitral valve treatment, and Acutus mapping here as well. We also, on the horizon now, have a new ablation catheter on the way, which will allow for potential compatibility with very varied mapping systems due to its modular platform. It will have multiple, now 8 navigation magnets, allowing for increased flexibility and mobility, and a tip with more than double the magnetic material. Should really be a step forward that we're looking forward to. And really bringing forward the question now of where do we go from here? We're really finally moving forward with a new paradigm, we think, allowing the combination of the robotic systems, the new catheters, the integration with X-ray and imaging, user interface such as the Odyssey system, which allows VPN connections from all over the world. That will really be the basis now for a future that will move us out of our silos, allowing for telemedicine, for automation, integrated image-guided therapy, bringing all data together from multiple sites for big data analysis, and even potentially moving beyond EP. And for more information, I would like to invite all of you to the Society for Cardiac Robotic Navigation to join us and learn and work with us as we bring this forward. Thank you, Dr. Kuck.
Thank you very much, Peter, for a great short look into the past and a great look into the future of our technology. I just would like to remind everybody that you can forward questions to this symposium by using the EHRA.pigeonhole.at with the code 339153. Please use this chat format so that we can forward your questions to the speakers. I would like to introduce now the second speaker, who is Dr. Tamas Cd Turok from Erasmus Medical Center in Rotterdam, Netherlands. And Tamas is talking about robotics and efficiency. Please.
Thank you very much, Dr. Kuck, co-speakers, and also good afternoon for all of the audience. And as Pete mentioned, one of the major issues in the last 20 years was that there is a common perception that although this is a great technology, it might not be the most efficient way of ablating people with it. And with my talk, I really would like to prove that this is no longer a perception, but actually it's a misperception. And in the last years of my research, I focused on this. Here you see my disclosures, and I move forward. So if we go back a decade ago, we published first results about an all of a total group of almost 1,000 patients with all indications. And we realized themselves that indeed the procedure times are not yet great. So that was in 2011. So together with the industrial partner, but also with Erasmus MC, I aimed to develop a technique, and I call it a minimal invasive pulmonary vein isolation technique that can serve as a model how this robotic technology can move from a relatively slow procedure to actually, I believe, with the potential of being the fastest and the quickest PVI method on the market. For that, we needed major improvements of the core technology. And in recent years, there are two major improvements that made it possible for me to improve our lab efficiency. So one of them is on the right side, the ablation history. This is the oldest one. It is available since quite a few years. And this is a technology which shows us, it's a software that shows us the three-dimensional representation of the delivered energy in watt seconds. And the other, and I find it even more important, because radio frequency is a contact dependent technology, as Pete also showed very elegantly. So recently, for us, it became available in a module that shows us the quality of the contact. We know that with this catheter, we don't necessarily need contact force, but we really need to make sure that we have good contact in the treated tissue. In this slide, I would like to show you, this is a 2-minute movie, so I will not show the whole movie, but more or less how it works at the moment. So we do only 2 punctures on the right side, and we put mostly only 2 catheters. So this picture is from an early stage when I had a CS catheter and an ICE catheter. But nowadays, as you will see later, I use only a lasso catheter and an ablation catheter. The transceptor puncture is done with transesophageal echo guidance. And what you can see, I place the carto image you can see in this lower left panel on the niobe screen, and I work exclusively in the niobe screen. And here in the text, I summarize the most important things that are necessary to do it fast. So the catheter positioning is mainly based on the contact indicator. The ablation history is the main guide for the RF delivery. We always do VACA, and we try to do the VACA around both veins if possible. Of course, there are some anatomical variants when we don't do that. And we use still an edgeless sheath for the magnetic navigation catheter. And again, one of the most important things that developed in the last years, that we use relatively high force because we are aware of the relatively limited contact force. So having said this, when we compared our technologies that we use for pulmonary vein in the last years, we realized that using this technology, we have actually the largest first pass isolation effect using the remote magnetic navigation, much better than in cryoballoon and much better than in manual ablations. And when we look at first generation and second generation technologies within the same group, so within manual group, within cryoballoon group, within remote magnetic group, we realize that actually the largest improvement in the decreasing of the procedure times were achieved in a remote magnetic navigation. This shows to me that the potential was always there, but somehow, because of some limitations, we couldn't reach the potentially possible procedure times. And this is the same with an ablation time. And in order to prove that this is actually true, together with our colleagues, we set up a masterclass training in October 2020. And that's, I consider as the end date of this project, when we actually proved that you can really do fast procedures on a reproducible way. So in this day, we treated, as you can see in this very short summary of the day, 6 patients with a PVI in one single 8 hours working day. And you can see in a different patients, the shortest procedure time was around 44 minutes, and the longest procedure time, when it went a little bit slower, was 68 minutes. And just to say, because of the limited time we have as speakers, you can see the end. Last procedure, 4-6 down. Actually, it was done around 4:50, just before the end of our working day, and the last was 44 minutes. So just to show what we can achieve with this, we need, of course, experienced manipulators. My LA access time is 6 minutes from puncture. But again, what you can see, it's an almost continuous ablation of 33 minutes. I do drag lines. I don't do point by point with relatively low fluoroscopy dose. And what you can see that the whole procedure times on average in these patients, when I was able to do this minimal invasive technique, is around 60 minutes. So these are my conclusions. I think in the last 10 years, this technology grew to a very, very efficient and fast technology. And there are many things to improve in the future, but nobody can say that this is not an efficient technology anymore.
Thank you very much for this interesting and very updated presentation. Again, I would like to remind our audience to post their questions to the chat box. Meanwhile, I would like to introduce Professor Pekka Raatikainen to give his presentation, which will be the last presentation of this session, and it's on robotics in complex ablations. Please, Peter.
Thank you, Karl-Heinz, and thanks also for EHRA and Stereotaxis for arranging this fascinating Satellite Symposium, and greetings from Finland. So here are my disclosures. And this is our robotic lab in Helsinki University Hospital currently. We installed these Genesis magnets last summer and performed the first ablations in the worldwide setting with these new magnets in July 23rd, 2020. Currently, we are using this system every day, and like Peter was telling, it's very nice to have the Odyssey screen here. You can use one mouse, one keyboard for everything there. So this is really fascinating technology. I've been really happy to be able to use it for more than 10 years now. So why are we using robotics in complex ablations? I've summarized something here. We feel that catheter precision, reach, and stability are better than in manual ablations. We can even perform retrograde ablations in left atrium in patients with congenital heart disease or vascular abnormalities. The safety is improved a lot. We can't really perforate the heart with the soft magnetic catheter. Radiation exposure is much less with the magnetic system than manually there, and operations are less complex. I really like that we do not need to wear lead apron or sterile clothing while we are mapping and doing the ablations in complex cases. And last but not least, the learning curve for magnetics or robotics is much more shallow than for manual ablations. So taking it together, I think that the patients are feeling better when we are treating them better with the magnets or robotics there, and especially that the operators will stay much healthier when they are not doing the long cases wearing the leads for 8 hours or so. So I picked some cases what we have done using the robotics there. This is a patient with idiopathic ventricular extrasystole and short runs of VTs coming from the distal coronary sinus. It's very simple to map the heart with this technology there. This is the LV outflow track, and this is the aortic root there. Unfortunately, we are not able to terminate the extrasystole, but we put the catheter deeply inside the coronary sinus, and here in the distal coronary sinus we were able to eliminate these extrasystole. In our experience, it's much easier to take the soft magnetic catheter to the distal coronary sinus than the stiff magnetic manual catheter. This is another example, 39-year-old female, lots of extrasystole, something like 45,000, every Holter record is beta blockers, calcium channel antagonist, flecainide, prior endocardial ablation has failed. And this is the EGG pointing out that this might be epicardial foci in this case. So we did the mapping with the stereotaxis system, going first to the LVO outflow tract area, tried even some ablations there like in the past. In the prior ablation, no success in that area. Reasonable base map, but you can see that the Pasha correlation was only 0.84. So this is the epicardial map now, just on the opposite of the endocardial best sites there. In that area, we were a little bit earlier, and the base map was much better, and we eliminated completely these extrasystole, and the patient has been feeling well for a couple of years now. Another example, this is an epicardial ablation in a patient with ARVC, right ventricle outflow tract showing scarring there, no scarring in the left ventricle here. Unipolar map pointing out that there might be even larger scar in the epicardial area. This is the epicardium, and with epicardial area, it's very easy to map with a soft magnetic catheter. It goes fluently there. It's simple to map, and we were able to ablate all these fragmented areas here and eliminating the VT in this patient. Another example, post-MI patient, these are the cases that we are treating mostly with the stereotaxis system. Here's one channel showing the ripple map, another channel here showing the ripple map, third channel here, and ablating all these channels with the stereotaxis, we were able to eliminate all VTs in these patients, and no VT were inducible at the end of the case. So this is not any more VT, this is even more complex case. This is a patient with transposition of the great arteries, which was corrected in the childhood with the mustard technique. This is showing the blue atrium here. We can see when mapping during the tachycardia that there was some early activation here, close to the tunnel area there. Then continuing, in this case we did it via the powerful puncture there, mapping also the red atrium here, and here we can see that in this case there was in fact a small re-entry going around the patch that the surgery had put on during the surgical case in the past there, and ablating, connecting this small scar to the pulmonary vein, we were stopping the tachycardia in this case. Oh, it was not advancing at once. So I think that many procedures that cannot be done manually can be done with the remote magnetic navigation. And here I'm sitting in Dubai in the auditorium. Patient is in Helsinki. I was isolating the pulmonary veins with no problems there. Getting the isolation done and mapping is nicely done even from 6,000 kilometers away. So thank you for your attention.
Thank you very much, Pekka. I just remember that Carlo Papone did this once during the Boston AF meeting. He was sitting in Boston and did an ablation at San Raffaele in Milano using the stereotaxis system and successfully.
Yeah, there's a big difference in a way that the technique has been advancing. I was using my laptop. During that time when Karl was doing the case, there was a couple satellites and it was 100,000 euros. This didn't cost anything extra for us to do it. So I think that the internet is providing the same as when Karl was doing the case, he was having, I think, 2 or 3 satellites, 100,000 per hour for something like that. So the technology is really improved a lot.
Of course. I mean, for the VT cases, just let me come back to the VT cases. One of the limitations sometimes of using manual catheters in patients with VT is that particularly in smaller hearts, you introduce a lot of ventricular premature beats during the mapping. How does that compare in your experience using this robotic catheter, which of course is much softer, as we all know, than a regular ablation catheter?
Yeah, I think it's a major advantage for the system there, that especially for the healthy hearts, that you're mapping the extrasystole into outflow tracts areas, that it's so nice that it doesn't induce so many extrasystole. I think your group has even published some paper showing that it's less extrasystole with the stereotaxis catheter than with the manual catheter. I really like it because of that. It's not so important during the scar reentrant VTs. There perhaps not so many extrasystole in the scar area there, but it helps the mapping, and we can do everything just using the transceptor puncture. In the past, I was doing retrograde and transeptal access manually there both ways. Now I'm doing only transeptal access. If it's limited, I can do everything retrograde also.
So if you have a case like the cases that you showed where you needed an epicardial approach, do you do the epicardial approach? Because otherwise you have to go back into the lab and do it again. So one of the advantages, once you have the catheter in place, you can do everything from outside. So in these cases, like the typical case where you have this Q wave in 1 and a positive in 2 and 3, the delta wave indicating an epicardial origin, did you do the puncture from the very beginning and then do the map with the stereotaxis system from the very beginning too?
Yeah, if we go for epicardial, we always do the puncture first, the pericardial puncture first, then we can do mapping inside the heart. And because if you start mapping inside the left ventricle aortic root, then you have to give heparin there. And I feel safer to do the puncture before that. In this case, the patient had already failed endocardial ablation, so it was straightforward to just go epicardially there. But like I showed, I mapped also the endocardial space and even tried to ablate with no success.
Thank you. Tamas, you didn't talk about the longevity or the durability of lesions. You mentioned the acute results, that they are similar when you isolate first pass the pulmonary veins between the different technologies. Would you like to address also a word how this compares during long-term follow-up in these patients? Is it a durable lesion that you can create with this very soft catheter, which has the advantage to be in contact during systole and diastole as compared to the stiff catheters that are only in contact during systole? Any experience here?
Yeah, sure. Of course, it's a very important question. It was beyond the scope of my 5 minutes talk to address this as well, but I think it's actually the crucial question. Speed is not everything. We really need the durable lesions when we go into the human heart and then try to limit the redo. So when we look at our redo ablations in the last years, since we do this relatively high power ablation, we don't have any data suggesting that those lesions are worse than any. Some data showing that those are better. Not necessarily for PVI. So for PVI only, it's very similar in a cryo group and in a manual group in terms of redo procedures. On the other hand, at the moment, when you decide to do some substrate ablation and moving either mapping-based substrate ablation, and then you connect some sources with lines to non-conducting tissues, or you do posterior box isolation, then there are clear data that, at least in our hand, we have much less recurrences in the magnetic navigation group than in the manual group.
I can also
when you do anterior line, I think it's manual. It's very challenging, and this is just very easy.
Okay.
I was going to say I could address that briefly too. We published over 650 patient case series for atrial fibrillation, and half the patients manual, half robotic, and 1 year and 3 year clinical outcomes were identical. And again, with the legacy technology, right? So we're comfortable that we're certainly not doing any worse with clinical outcomes, and we're really poised to move that forward. We hope as well.
Pete, my last question goes to you. You mentioned what has been done over the last couple of years. Now, most of the young electrophysiologists today are using high-density maps, even in regular cases with atrial fibrillation. So they don't like to do point-to-point maps. How do you see the integration or the future of high-density maps with multipolar catheters? Do you think that's something that should also get implemented into robotic navigation and then finally ablation?
Yes, you're absolutely correct. Really, the key is to have this open ecosystem to allow for integration of the different ablation systems, the different ablation energies, the different mapping systems, integration with not just high-density mapping, but also with the anatomical information now coming from our integrated CT and MRI data as well, that will allow us to have true tissue characterization in real time when we're doing our work. And so I absolutely agree that putting all these technologies together will be key to increased adoption and to keep each operator the opportunity to use whichever tools they think are best for that particular patient with real freedom.
Okay, thank you so much. I think that we have come to the end of our interesting session. I would like to thank you, the three speakers who made this symposium so successful. I again would like to thank Stereotaxis for supporting this interesting meeting, and of course EHRA for putting this on the program. So thank you very much, all of you, and I wish you all a nice weekend, or the rest of the weekend. You start into the weekend, and I wish you a successful day, and thanks very much for being with us. Goodbye.